Good afternoon, everybody. I'm very happy to be here with you, and I would especially thank Nada for a warm welcome. Today I will talk about the differential diagnosis of pancreatic lesions. Let's start with a little bit of background. Pancreatic lesions are solid and cystic lesions. They are increasing. In Western countries, the incidence of adenocarcinoma increases by 3% each year, and we estimate between 2 to 45% of the general population will have a cystic pancreatic lesion during their lifetime. It is due to the improvement of imaging detection and the aging population. The main goal in managing pancreatic lesion is to identify those at risk of cancer for early treatment while avoiding overtreatment of benign lesions. When we discover the solid pancreatic lesion, patients may present some symptoms such as weight loss, abdominal pain, acute pancreatitis sometimes, jaundice, diabetes mellitus. CT scan is often the first imaging performed. It shows you an heterogeneous nodular lesion, more or less a dilated pancreatic duct or a dilated common bile duct, in particular if the lesion is located on the head of the pancreas. In blood, we may have an elevated CA19-9 and IgG4, but we have to keep in mind they are not perfectly reliable tests. Discovering a solid lesion does not necessarily mean adenocarcinoma. In several studies, it has been shown the solid lesion will be an adenocarcinoma between 55 to 70% of cases. In 1/3 of cases, it would be another things, inflammatory lesion, neuroendocrine tumor, or maybe a metastasis. That's why we need to perform some exam, CT scan if it has not been already done, MRI and EUS, and sometimes biopsy. These pictures show you the same lesion, the nodular lesion responsible for dilated common bile duct and dilated pancreatic duct there on the MRI and in the EUS picture. We can study the vascular structure thanks to the Doppler and perform a biopsy if necessary. Most often patients are referred after the incidental discovery of an asymptomatic cystic pancreatic lesion. This is due to the improvement of imaging. The prevalence in general population is around 55 for having a cyst during the lifetime, and thanks to the improvement in imaging, we detect most of those lesions. Age is another important factor. The older the patient, the higher the risk to discover a cyst, in particular after 50 years old. These charts show you the distribution of the cyst. In fact, in 20% of cases, it would be full cyst, mainly a pseudocyst or a dystrophic cyst. So in this situation, the medical history of the patient will be crucial to have an accurate diagnosis. And in 80% of cases, it will be a true cyst, mainly IPMN, intraductal papillary mucinous neoplasm, which is a benign lesion, but if the main pancreatic duct is involved, the risk of malignancy exceeds 50%. It can be also serous cyst. This is a benign lesion and remains so. And in the middle, we have other lesions, mucinous cyst, neuroendocrine tumor, solid pseudopapillary epithelial neoplasm with intermediate risk. I will develop those types later. At this stage of the management, we have to wonder whether continue investigations, because the follow-up may be quite long and responsible for anxiety for the patients. The treatment is surgery, which carries a risk of 30% risk of complication and 2% risk of mortality. So we have to give the patients information about the risk and the benefits. And finally, the follow-up should be only reserved for patients fit for surgery. What are the diagnostic tools? In blood, there is currently no available blood test for clinical practice. Imaging is much useful. CT scan without contrast show calcification very well, but the accuracy for cystic pancreatic lesion is not perfect. That's why the CT scan is better for suspected cancer, tumor staging, or suspected current disease. MRI is more accurate for cystic lesions in the pancreas. It is able to detect communication very well with the main pancreatic duct and to identify mural nodules, as you can see in this example. And it's very interesting for the patient to avoid radiation exposure. EUS is another diagnostic tool. He has a very good spatial resolution. He can identify communication with the main pancreatic duct very well. With the contrast, we can see the mural nodules very well with an accuracy around at 98%. EUS is also better than CT scan to diagnose cancer. The main limits are the cost and the need for general anesthesia. If necessary, thanks to the EUS, we can perform a biopsy. A biopsy to take some cyst fluid and perform measurement. DNA markers are promising but not available for clinical practice, whereas we can test CEA and glucose, and the measurement allows you to differentiate mucinous from non-mucinous lesions. Let's see the main types. The intraductal papillary mucinous neoplasm represents 70% of the pancreatic cyst. They affect male and female equally. They are mainly located on the head or the neck of the pancreas. The main type is the branch duct IPMN, as you can see on this MRI or EUS picture. Sometimes the main pancreatic duct is involved as either segmental or a global dilation of the duct. And in this situation, we can observe a very specific aspect of the papilla, the papillus papillary. Sorry. In histology, this is a mucinous lesion with a risk of malignancy around 40% if the main pancreatic duct is involved after 5 years of progression, and 100% of malignancy after 15 years of progression. When this is the branch duct involved, the risk of malignancy is low, but it's not zero. The risk of cancer comes from the IPMN, of course, but also from the Panin lesion. This is a pancreatic intraepithelial premalignant lesion developed on the small duct of the pancreas. So this is crucial during the follow-up to examine always the entire pancreatic gland to detect both types of cancer. This chart shows you how to manage IPMN. It is available in the review GUT 2018. Just remind you, we don't follow the patient who are not fit for surgery, and the decision to monitor or to treat the patient is based on several criteria. And the absolute indication for surgery are as follows: a positive cytology for malignant or high-grade dysplasia, the presence of jaundice or solid mass, an enhanced mural nodules over 5 mm, or a main pancreatic duct dilation over 10 mm. The second type is the serocystic neoplasm, 20% of the pancreatic cysts. It affects female around 60 to 70% years. It is located everywhere in the pancreas, a little bit more in the head. We can see a central calcification on a CT scan without contrast. It is due to the long-staging nature of the lesion. The main type is the macrocystic type due to numerous cysts inside the lesion. And it gives the very specific aspect of honeycomb on EUS. There is no communication with the pancreatic duct and no dilation of the duct. It is a benign lesion and it remains so. But Sometimes the serous cyst is associated with a main pancreatic duct in 10% of cases and associated with branch duct IPMN in 15% of cases. So it can be very difficult to distinguish a serous cyst from other things. In this example, it seems there is a communication, but in fact it was a serous cyst. And sometimes the serous cyst it looks like a macrocyst in the body and tail, so it can give the impression it's another thing. Here is two examples. It looks similar, but in fact this one was a serous cyst, and this one was another types. So when it's difficult to have a diagnosis, we perform a biopsy with the EUS. And this other type was a mucinous cystic neoplasm. The MCN represents 7% of the pancreatic lesion. They affect female, around 40 to 60 years old. They are located on the body and the tail. And they have a true wall cyst with a brief and moderate parietal contrast enhancement, sometimes peripheral calcification, no communication with the main pancreatic duct. In histology, this is a mucinous lesion with a risk of malignancy can reach 30% after 5 years of progression, in particular if the lesion is over 4 centimeters with an irregular thick wall or peripheral calcification. And in those cases, we have to operate the patient when it's possible. The last type is the solid pseudopapillary epithelial neoplasm. It is 2% of the pancreatic cyst for young women mainly. They are located in the body and tail, and they have everything mural nodule, peripheral calcification, and solid component. It is a promalignant lesion. That's why we always operate the patient, and the prognosis is very good on condition that there is no biopsy before the surgery. Otherwise, we can have metastasis because of the parietal rupture. Cystic neuroendocrine tumors are rare. After 50 years old mainly, it needs a biopsy to have an accurate diagnosis, and we need to operate grade 3 and 2 neuroendocrine tumor. Sometimes we are not able to precise the diagnostic. If the lesion is smaller than 15 millimeters, the better things to do is to monitor the patient, and over 15 millimeters, we can perform a biopsy to have the most precise diagnosis. And if we don't know the diagnosis, we can also refer to an expert center. These two more slides, one chart to remind you how to manage the cystic pancreatic lesion. You can find the document in Gastroenterology Clinical and Biological. It's based on the communication with the main pancreatic duct, the number of cysts, the presence of through wall, mural nodules, etc. And finally, some take-home messages about the worrisome features. The presence of jaundice, a lesion over 4 centimeters, an enhanced mural nodules over 5 millimeters, a main pancreatic duct over 10 millimeters, or a positive cytology or the presence of tumor mass. EUS is a very good exam for spatial resolution to identify pancreatic duct communication, to perform contrast and biopsy, or to detect cancer. For serous cyst or pseudocyst, there is no surveillance and no surgery. There is always surgery for solid pseudopapillary epithelial neoplasm, and we have to decide between monitoring or